Just a quick prelude, Ankur, because I this is my first experience working with the European Society of Cardiology as a program committee member, and selecting the trials and the randomized and the late-breaking trials is never easy. But for interventional cardiologists, there's always an outpouring of data that comes out, and we have to process them because at the end of the day, they have to impact our practice. And so it was a tremendous learning experience for me as part of the committee to kind of go over these. And that's why I selected these 5.
When saving lives is what you do, your standards are anything but standard. In fact, you set them higher than most to deliver results that patients can depend on. You refuse to compromise. We couldn't agree more. We are Edwards Life Sciences, and like you, we believe that good is never good enough. Rising to the challenge of today's TAVR patients isn't just a mission, it's a commitment. And because you set a higher standard, we set our sights on meeting you there. Welcome to the higher standard, your standard. Learn more at edwardstavr.com.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD from the Cleveland Clinic.
Hello, everyone. Welcome to another episode of Parallax. Just before I start this episode, which would be a continuation of where Dr. Parvani left, Purvi Parvani, she discussed some of the trials which came out at the European Society of Cardiology meeting this year. I wanted to share with the listenership that Purvi's episode actually is one of the most downloaded episodes for the year. I think in terms of, matching that feat, I could not think of anyone else better than Dr. Alasnag, Mirvat Alasnag, and I apologize, Mirvat, if I'm mispronouncing your name, but Dr. Alasnag is the director of the cardiac catheterization laboratories at King Fahad Armed Medical Forces Hospital in Saudi Arabia, and is an international brand, as I was telling her, in the field of cardiac interventions, if not cardiovascular medicine. And, is a face that represents women in cardiology, women of color in cardiology, and also, ethnicity and diversity. So she holds a very special place within the cardiovascular disease community, at least for me. And it's truly my honor and privilege to have her as a guest on Parallax. So Mirvat, thank you and welcome on the show.
Well, thank you for having me, and thank you for this wonderful introduction. It's more than what I deserve, certainly. But the other thing I want to thank you for is your podcast and your theories. I've listened to many of them, and they're very easy to follow and very educational. So it's just something to congratulate you for at the start of this our session today. And hope you continue to register a lot more success in your future episodes.
Oh, well, thanks a lot for your wishes. So diving right in, because we have a lot to cover here, Mirvat. You picked 5 trials, which were all presented and published at the European Society of Cardiology meeting earlier this year. It was a virtual meeting, unfortunately, because of the pandemic. We've all transitioned to our virtual lives, but, regardless, I think the science has moved forward. Let's start by talking about STOPDAPT-2, which is one of the trials that you picked.
Yeah, so, just a quick prelude, Ankur, because, I this is my first experience working with the European Society of Cardiology as a program committee member. And selecting the trials and the randomized and the late-breaking trials is never easy. But for interventional cardiologists, there's always an outpouring of data that comes out, and we have to process them because at the end of the day, they have to impact our practice. And so it was a tremendous learning experience for me as part of the committee to kind of go over these. And that's why I selected these 5. The first was the STOPDAPT trial. Now, this comes at the heels of other trials, similar trials, and I think it's important not to interpret trials, in isolation or in a vacuum. It's important to understand where they come from. So the STOPDAPT-1 trial actually looked at cobalt chromium eluting stents, 3-month DAPT, abbreviated DAPT. It was conducted in Japan. Over 1,500 patients were enrolled, and 3-month DAPT and a composite of MI, stroke, and stent thrombosis was reported, and it appears it's safe to have an abbreviated DAPT. Followed by STOPDAPT-2, again conducted in Japan. They abbreviated the DAPT to 1 month and enrolled about 3,000 patients. Again, the similar composite endpoints of MI, ischemic or hemorrhagic stroke, and stent thrombosis. And for the primary endpoint, they registered non-inferiority and superiority. For the secondary endpoint, they registered non-inferiority but not superiority for the secondary endpoint of bleeding. But only 38% of those enrolled were patients with acute coronary syndrome. And this is where this trial comes in, which is STOPDAPT-2 ACS trial. They looked at 1 month dual antiplatelet therapy followed by clopidogrel monotherapy in patients with acute coronary syndrome. And in order to, have enough power to register results, they actually pooled the ACS patients from STOPDAPT-2, about 1,148 patients, and added them to new patients that were enrolled, 2,988, for a total of about 4,136. And 1 month DAPT with aspirin and clopidogrel, followed by clopidogrel alone, randomized 1-to-1 randomization, 12 months DAPT, aspirin, and clopidogrel. And the primary outcome, a composite of cardiovascular outcomes and bleeding outcomes at 1 year, was 3.2 for the abbreviated 1 month DAPT and 2.8 for the 12-month. And it was the p-value was 0.06 for the non-inferiority. For the major secondary endpoints, which included bleeding as well, it was 2.7 and 1.8 respectively for the 1 month DAPT as opposed to 12 months, and 0.5 and 1.1 for the TIMI major and minor bleeding. So 1 month DAPT followed by clopidogrel monotherapy failed to achieve non-inferiority for a net clinical benefit compared with standard 12-month DAPT in ACS. And there was a trend to lower toward an increased cardiovascular events despite a reduction in major bleeding. And so that kind of warrants that we stop and think it over, the abbreviated DAPT, particularly in patients who have acute coronary syndrome. So they're not all the same. So if I'm treating chronic coronary syndrome and considering abbreviated DAPT, the STOPDAPT doesn't apply to that category of patients. But if I'm talking about ACS, yes, I should think twice about abbreviated DAPT.
Yeah. So that's a great summary. So let me just ask you, in your own contemporary practice, and this is sort of something that applies to my practice also. We have data for this. So I've started saying in my notes, in my post-CATH, post-PCI notes, I definitely say uninterrupted dual antiplatelet therapy for at least 3 months. And, if I'm using ticagrelor, I say aspirin and ticagrelor. Then, there's data which, is from the other trial, not presented at this meeting, but there's published data that you have the option of ticagrelor monotherapy that is efficacious in patients with ACS. And now you've got STOPDAPT-2 with abbreviated Dapt strategies in patients with acute coronary syndrome. And then you've got patients who have stable CAD or chronic coronary syndromes. So there's a spectrum here. There's a spectrum of disease states that we see here. So in your practice, if you're using ticagrelor is the P2Y12 inhibitor of choice for Dapt, what is the recommended strategy that you follow in ACS patients? That's question one. And then question two is, if you're using clopidogrel bisulfate as your P2Y12 inhibitor of choice in Dapt strategies, what is the strategy that you follow in your patients with ACS? And then I'm going to follow up and request you to extrapolate the the same questions for the stable CAD population.
Right. So for ACS patients, I think when we do look at the guidelines, they do recommend, the guidelines have shortened it from 1 month to 6 months and so on. But the key is to look at not just ACS in the presentation of the patient, but to look at their bleeding risk. So if these are high bleeding risk patients from the get-go or they're not. And I think it is important, by default, we also know from several trials that bleeding is associated with higher mortality as well, overall mortality. And so for my patients, I do try to keep the DAPT abbreviated, whether it is with ticagrelor or clopidogrel. And I think it's important to understand that patients at discharge, events may happen post-discharge. And so when I see them again, even if I have planned 3 months of dual antiplatelet, and I need to revisit that at 3 months or at 1 month, if they've had an event in the interim, if it's a bleeding event, then I certainly would want to abbreviate it from 3 months down to 1 month. If they had an ischemic event of the sorts, then I don't want to abbreviate it. So I think I don't want to confuse the listeners, but what I do want to say is that it has to be a continuous decision that we revisit every time we see our patient. Has anything changed? Is the patient's bleeding risk the same as when I cath the patient and planned 3 months for ACS of dual antiplatelet? If it is the same, then I continue as planned 3 months and then monotherapy. If anything has changed, then I either reduce the dual antiplatelet therapy regimen to 1 month and continue with monotherapy. If they've had a bleeding event, if they've had an ischemic event, then I consider extending it longer than 3 months. And then moving on to your second question, which is for stable coronary disease patients. Again, what I would do, and I think there's some reference from other trials where, I still don't have the courage to do that, where, 1 week of dual antiplatelet and upon discharge or later on, you can continue monotherapy. So I generally would give 1 month of dual antiplatelet for stable disease, non-complex coronary interventions, meaning bifurcations, rotablators, etc., and then continue with monotherapy thereon. But again, similar to ACS patients, I think it is critical that we revisit it every single time.
Yeah, and then you mentioned something which is important. I think it's an important decision to be made at the bedside or when evaluating the patient at discharge, and that is, how do you ascertain their bleeding risk? What are some of the tools that you use to ascertain their bleeding risk?
So I think, there's several scores that are available, the Hasbled score, the Paris score, et cetera, that depends what your comfort level is and what you're used to and what your institution has adopted. A lot of them are very similar. You look at the age of the patient, you look at if they've had any recent bleeding, any requirement for transfusion, GI bleeds, hemorrhagic strokes, etc., anemia, if they require oral anticoagulation for whatever reason, and you look at those. And that's how we kind of determine the score of the patients, their bleeding risk. What is interesting, though, and what is important is that we remember we're clinicians at the end of the day, and that all these scores have a significant intersection. A lot of the factors that we think render patients at high risk of bleeding also render them high risk for ischemic events. So age, for example, prior strokes, etc., chronic kidney disease, there's significant overlap between the two scores. And so at the end of the day, we need to be clinicians and and individualize it to the patient in front of us. And even for that individual patient, I can't stress enough, is to revisit it every time we have a clinical encounter with our patients. Excellent.
Excellent summary. So moving on, the second, and by the way, I want to congratulate you on being, such a representation and force as part of the committee to pick these trials, and also to pick these trials for this iteration of the podcast, because, like you said, these are important data, and these are data which are both practice informing and practice changing. So I think it's important for us as clinicians to stay on top of these data and sort of, implement them as we see our patients in clinics, in the cath labs, in the hospital. So thank you for the service, for all that you've done for the cardiovascular community. So moving forward, let's talk about the Tomahawk Trial, which I think is an interesting name, but again, something we encounter commonly as interventionalists in our practice. Do you want to, talk more about the Tomahawk Trial?
Yeah, sure. So the Tomahawk Trial, and just again, we have to interpret everything in the context of clinical practice. So what is currently happening? Patients who have an outside of hospital cardiac arrest, as soon as they are rushed to a hospital, as soon as circulation is established and they're rushed to a hospital, the practice has been pressure on interventional cardiologists to take them immediately to the cath lab. So the Tomahawk Trial, the objectives of it was to look at whether immediate coronary angiography for treating or ruling out an acute coronary syndrome as the reason for the cardiac arrest or outside of hospital cardiac arrest. And so they looked at these patients who are survivors of outside of hospital cardiac arrest without an ST elevation MI. And they wanted to see if randomizing them, again, 1-to-1 randomization, immediate coronary angiography plus minus PCI, or an initial intensive care unit assessment with delayed or selective angiography as need be. And they wanted to see if that would result in a reduction in all-cause mortality at 30 days compared with an initial immediate coronary angiography. And they enrolled any patient over the age of 30 with successful resuscitation after an outside hospital cardiac arrest with possible cause. So they had non-ST elevation MI on EKG, and they had either a shockable or a non-shockable rhythm. They had over 550 patients. As I mentioned, the primary outcome was all-cause mortality at 30 days, and early angiography was not superior to a more delayed strategy. So the all-cause mortality at 30 days was 54%. For immediate angiography, and it was 46% for the delayed or selective approach, with a p-value of 0.058. So there's really no difference in the primary endpoint, and it was very similar for the pre-specified subgroup of those who were with shockable and non-shockable rhythms. So even those with shockable rhythms, if you choose, to evaluate them better, stabilize them, perhaps start hypothermia and so on, and then do angiography, the results were very similar. The secondary endpoint, all-cause death or severe neurologic deficit at 30 days, again, was more frequent in the immediate angiography group compared with the delayed. And so overall, early angiography in outside of hospital cardiac arrest without ST elevation MI, it was not superior. And I think it's very important because it relieves the pressure from interventional cardiologists to just rush, and requires that we just evaluate patients. We evaluate them. Could it be something else, particularly that these are non-ST elevation MIs? So could it be pulmonary embolism? Could it be anything else? Or could it, yes, in fact, be an acute coronary syndrome, a ruptured plaque somewhere, and they benefit? But no harm in stabilizing the patient, their hemodynamics, their respiration, and so on first.
Yeah, so, personally, I was also pleased with the findings of this trial, and it's something which resonates my own practice clinically. And that is that if there is ROSC, which is, return of spontaneous circulation, and if there's no acute current of injury on the electrocardiogram, no ST elevation, then I tend not to take these patients, pending, other things, right? Ascertainment of neurological recovery, whether or not they require targeted temperature management, which we know interferes with, how effective dual antiplatelet therapy is in case they need percutaneous coronary intervention. So I was sort of, both relieved and happy that that's what the randomization showed, because it sort of resonated with how, most of us practice cardiac interventions, here at the Cleveland Clinic, and I'm sure, elsewhere also.
I think what this is going to do going to force a conversation between the interventional cardiologists and the critical care experts very early on. And I think that's important because, when these kind of patients are delivered to hospitals or transferred to hospitals, they're rushed into the cath lab and the conversation happens in retrospect. I think what it does is it starts the conversation early with our critical care colleagues, and it also starts the conversation with the family early, when these kind of patients are rushed to the cath lab, we end up speaking to the family in retrospect. This is what we found on angiography. We're looking for another cause. We're not sure that this anatomy explains what happens, etc. But it helps us start this conversation both with the family and the critical care cardiologist, function as one team, come up with one, multidisciplinary plan, and honestly figure out futility, prognosis, etc., in a more controlled environment. And I think that is important to set those kind of expectations for family in these very critically ill patients.
Yeah, no, I couldn't agree with you more. So moving on, Mirvat, the next trial that you've picked is an area of personal interest. It has been an area of clinical investigation for me personally. And that is, utilization of DOACs in patients with prosthetic heart valves. Here, we're talking about a special population. We're talking about patients who undergo transcatheter aortic valve implantation, so TAVI. So these are patients with aortic stenosis, and not uncommonly, as you know, these patients have atrial fibrillation as one of their comorbidities, or if atrial fibrillation happens following the procedure. And then it becomes a conundrum, whether they should be on dual antiplatelet therapy, single antiplatelet therapy, dual antithrombotic therapy, whether they should be on warfarin, should they be on DOACs. So we have a lot of options. There is no clinical answer, which is supported by a randomized clinical trial. The one trial which was done in patients without AF showed that single antiplatelet therapy is as good as dual antiplatelet therapy in these patients. We've published meta-analyses on this topic. So this comes at a great time when there is definitely an unmet need for answering this question. And the results were presented by Dr. Dangus. The first author is Dr. Nick Van Meeghem, who all of us know, published in the New England Journal of Medicine. Congratulations to all the authors. You want to discuss the results of this trial. It's called Envisage TAVI AF, published in the New England.
Absolutely. And I just want to kind of catch on something you mentioned moments ago, which is, AF is not uncommon in patients with aortic stenosis, severe aortic stenosis undergoing TAVI. In fact, the incidence or prevalence, ranges from 20 to 40%. Of the patient population that's being treated with TAVI. And so it is important that we address it. And it seems to me that the technology and the procedure itself has taken huge leaps, and yet the ideal antithrombotic regimen has lagged behind, or the evidence for it has lagged behind, and hasn't taken as fast steps in terms of generating the evidence. So the Envisage TAVI, again, comes at the heels of two other trials. One was the Galileo Trial, which looked at low-dose rivaroxaban, and unfortunately was terminated early because of higher events in this patient population. And the events were actually, they gave 10 milligrams daily of rivaroxaban, and there were higher events in terms of death, thromboembolic complications, and also bleeding compared to antiplatelet-based regimen. So the other trial was the Atlantis Trial, where they looked at patients who have had an indication for oral anticoagulation, such as atrial fibrillation, and ended up getting apixaban for those patients, 5 milligrams BID, compared with dual antiplatelet. Apixaban was not superior. There was a concerning signal to higher events in those with requiring oral, with an indication for oral anticoagulation in the DOAC arm. And so it warrants further exploration. But for patients who cannot tolerate vitamin K antagonists, the conclusion of that trial, the Atlantis trial, was to go ahead and give apixaban. So the Envisage trial was actually a very respectable trial. It was looked at 14 countries across 3 continents, 173 medical centers, over 1,400 patients were enrolled, and they were randomized to edoxaban and vitamin K antagonists, which were started either between 12 hours and 5 days after a successful TAVR implant. And they followed up these patients for an average of 18 months. The primary efficacy endpoint was a composite of adverse clinical events for all-cause death, myocardial infarction, ischemic stroke, systemic thromboembolization, valve thrombosis, and major bleeding. And, looking at it in terms of non-inferiority, the edoxaban arm for the composite adverse clinical events for the primary efficacy endpoint was 17.5 and 16.5 for the VKA arm. The primary safety endpoint, incidence of major bleeding, was 9.7 for the edoxaban arm and 7.0 for the vitamin K antagonist arm. Higher risk of major bleeding in the edoxaban arm versus VKA arm, and mainly driven by GI bleeding. The secondary analysis, patients who required a downward dose adjustment and those not prescribed an oral antiplatelet therapy had similar rates of major bleeding compared with the vitamin K antagonist group. And so edoxaban was non-inferior to warfarin and any of its analogs to adverse clinical events in patients with atrial fibrillation after successful TAVI. But the incidence of major bleeding was higher with the edoxaban arm compared to vitamin K. And so the prevalence of pre-existing or new onset AF warrants, a lot of caution when we're considering what kind of regimen we want to start. And there's not a whole lot about the efficacy of direct-acting oral anticoagulants versus VKA, aside from these three trials that we mentioned, looking at all three different DOACs, meaning edoxaban in this trial, the envisaged TAVI AF, Galileo for rivaroxaban, and Atlantis for apixaban. The only other concern, and I'm not sure if you do it routinely in your center, Ankur, is looking at, leaflet restricted mobility and looking at thickening. We know from the Galileo 4D, and we also know from the Atlantis sub-study looking at CTs of patients who had TAVI procedures, that those who received the direct oral anticoagulants actually had less thickening and less restriction of mobility. But there was very little clinical correlation. Now, to my understanding, this trial, the envisaged TAVI, did not have an arm that actually looked at a CT sub-study that looked at thickening and so on. But I think that is another area that we need to explore more. And I'm not sure if what you do in your practice. So if somebody does come with clinically, higher gradients across the newly implanted valve, and you see thickening and halt, as they call it, leaflet thickening and restricted mobility, do you convert them from antiplatelets to oral anticoagulants? Because that is what we do at our center. Nevertheless, the evidence and the clinical correlation is very, very limited.
Yeah, so that's the vexing question, right? And actually, what I do is I prefer to put them on warfarin because I'm not convinced that any of the DOACs have shown convincing. I mean, you're right. Non-inferiority, which now was shown with edoxaban and also with apixaban, but not with rivaroxaban. And with apixaban, for some reason, there was a signal toward increased non-cardiovascular mortality in those patients in the Atlantis trial. So I'm still on the fence and not convinced that oral anticoagulants are the way to go in patients with prosthetic heart valves. We certainly know that they're not safe in patients with mechanical valves. Their use is off-label in patients with bioprosthetic valves, and I'm talking about surgical valves. So now we have a lot of patients, over hundreds and hundreds of thousands of patients with transcatheter heart valves. And, as we've both discussed earlier in the show, that AFib is a common comorbidity. And I sort of struggle with the decision making, quite frankly. But what I do is, if there is evidence for increased gradients on follow-up transthoracic echo, or if for some other reason we've decided to obtain a CT scan and that shows any evidence for either leaflet thickening or restriction of motion, halt and ham as the literature calls it, I tend to put these patients on warfarin, and because I feel that is just the safest way to go for our patients. And I know there's lack of hard clinical outcome data, as you mentioned, and I can tell you that across the spectrum of practitioners at our institution, that practice is not uniform or standard. For example, if someone is on pre-existing oral anticoagulant, a DOAC, and gets transcatheter heart valve, there's a likelihood that he or she's going to get discharged on DOAC with or without aspirin. Now, is that backed by sufficient safety data? I'm not certain.
Yeah, and I agree with you. I think I would follow lead of the surgeons, because that is what they do with bioprosthetic valves. They put them on a short time of warfarin or vitamin K antagonists. And I think until we have more concrete evidence, that's probably the way to go if we detect an increase in gradients or realm or halt on our patients. And I think it becomes particularly difficult to make a decision in patients who have an indication for antiplatelet. For example, patients who have prior stents and so on. And so you have to kind of evaluate these patients. And we were talking moments ago about the evaluating the risk of bleeding in our patients. And so patients who have a TAVR valve and have stents and an indication for oral anticoagulation, it becomes very difficult to make the decision to go with only a DOAC and no antiplatelet, or just an antiplatelet and no oral anticoagulation, and so on. So the decision becomes even more complicated, and again requires a lot of individualized risk scoring.
Yeah, no, I couldn't agree with you more. I mean, these decisions are for the most part individualized, to patients, and depends on how they've done with follow-up. Now, I'm not saying that these should be generalizable. I mean, a lot of the patients actually do just fine with DOACs on board. So I don't want the listeners to go home with the message that DOACs should not be used in the TAVI population. That's not what I was trying to say. The only thing that I was trying to say was that, we're still learning about these agents in patients with prosthetic heart valves, and, not every patient is the same. So our index of suspicion should be high if there is an abnormality documented on echo or CT, and our threshold for transitioning to warfarin or a more traditional oral anticoagulant, like you were saying, how the surgeons practice, should be lower. That's all I was saying. So moving forward, the next trial that you've picked for us is RIPCOR-2. Again, something we commonly encounter in the cath lab, is extremely relevant to our practice. So why don't you tell us about the background, the rationale for conducting a study like this, and what the investigators found? I believe the primary investigator was Dr. Curzon.
So after the complete study, we now know that we really should be looking at vulnerable plaques and not just percent stenoses. And we know that we don't want to just treat the culprit vessel. We want to do complete revascularization in our patients. And so the Flower MI study that was published in July in the New England Journal of Medicine looked at FFR guiding multivessel PCI. And unfortunately, that trial, the conclusions was that in STEMI, in patients undergoing revascularization, an FFR-guided strategy did not have a benefit over angiography-guided strategy with respect to death, MI, or urgent revascularization at 1 year. But this trial was fairly different. The trial, RIPCOR-2, it didn't look just at STEMIs or acute coronary syndromes. It was, they cast a much, much wider net, which I think confused us as interventional cardiology community. And what they did is they took anybody undergoing a coronary angiography for investigation, whether it was for chest pain evaluation, angina, non-STMI, what have you. They did FFR on all vessels that they could perform FFR on with a stenosis of more than 30%. And they enrolled over 1,100 patients and randomized them to angiography alone and systemic pressure wiring after angiography, so FFR of all vessels. And the objectives of the trial is, to examine whether systemic FFR assessment of all relevant arteries at the diagnostic angiogram provides superior source utilization, so cost efficacy, quality of life, and clinical outcomes compared with angiography alone. And they evaluated these at 1 year. So when they looked at cost, FFR plus angiography, it was no better than angiography alone. It was not cost saving. When they looked at quality of life, whether they looked at it from the Euro Quality of Life Survey questionnaire or the Canadian Vascular Society scale, there was no difference between the two groups, looking at quality of life and angina status. When they looked at that was the co-primary outcomes. For the pre-specified secondary endpoints, clinical events, be it all-cause mortality, non-fatal stroke, non-fatal MI, and unplanned revascularization, again, there was no difference. And so overall, adding systemic FFR to angiography didn't reduce cost, didn't improve quality of life, didn't add to the final decision-making, and didn't reduce major adverse cardiovascular events or future revascularization. And I think the problem here is that it wasn't very realistic, and it did not replicate what we do in real life. And I think it tried to answer too many questions in one study. So, it's very difficult to lump chest pain, angina, acute coronary syndrome, all in one trial. And certainly, doing physiologic or functional testing in lesions of less than 30%, or more is a little bit of a stretch. That's my interpretation. Perhaps revisiting, the role of FFR in stable disease alone, perhaps revisiting it, in future trials with acute coronary syndromes outside the setting of STEMI, I don't know if we would have found a difference. What I do know is that when we're looking at complete revascularization, imaging seems to yield results that could guide us. So when we look at the complete OCT sub-study, for example, they did find that that lesions that were significantly stenotic with vulnerable features, thin-capped fibroatheromas and so on, there was a benefit in revascularizing those with reduction in future events. It was a very small study. Perhaps it needs to be, replicated in larger randomized trials where we're using OCT or even IVUS to examine these patients. How we can kind of, merge functional data and imaging data to determine which patients benefit from complete revascularization, I personally still don't know. And certainly the role of physiology has been a little disappointing for me as a clinician. I'm not going to say disappointing. Perhaps the correct word is frustrating, because none of us want to be just putting stents randomly in patients with stable disease or chronic coronary syndrome. And many of us do want to be evaluating some of these borderline lesions with physiology. I don't think the Ripcord 2 trial helped in that respect. What are your thoughts, Ankur, on that?
Yeah, no, I agree. So, personally for me, I think I reserve FFR to, just like you said, patients with stable coronary disease. I don't think I sort of extrapolate the validity or the findings of FFR in patients with an acute coronary syndrome, and that involves the entire spectrum of acute coronary syndrome, whether it's unstable angina, whether it's non-ST elevation myocardial infarction, certainly in patients with ST elevation myocardial infarction. I think in patients with STEMI, complete revasc, we have a lot of trials, we have a lot of data. I think that's the strategy in those patients to move forward. I think it's just a little different when it comes to patients with stable disease, and I think that's where the value of FFR holds for me as a practicing interventionalist. I agree with you. I think these are separate patients, and these are separate patient populations, and these are separate pathophysiological mechanisms. When we're talking about the underlying substrate for these patients, certainly the ones with acute coronary syndrome have a higher event rate, have a higher annualized event rate, and I think completeness of revascularization based on imaging and based on plaque vulnerability makes a lot more clinical and physiological sense to me as a practicing interventionalist compared with, for example, FFR, to the point that I have stented lesions with unstable plaque, even though the FFR was normal. And I know there are more data accruing. I mean, there are randomized data accruing for this practice, for the statement that I just made. But, clinically, it just makes sense that that's the right thing. I mean, why would you leave a vulnerable plaque, which has declared itself, so to speak, unrevascularized, only to expose the patient to downstream events in the ensuing 1 year? Don't you agree? Would you agree with that, Mirvat? Or
no, I absolutely 100% agree with you, and I think the Ripcord-1 trial was on target, because what they did is they didn't really confuse patients. They didn't confuse the cohort that they were evaluating. They just took patients with stable chest pain who underwent coronary angiography for whatever indication, and then did FFR on these patients. And what was interesting is that 26% of the patients who had FFR had a change in the strategy, in the plan of care after doing the FFR. And that is ultimately what we want. We as interventional cardiologists want a tool that will guide us in making the appropriate decision for our patient. So will they benefit from a stent and then the ensuing dual antiplatelet therapy, or am I subjecting them to unnecessary exposure to dual antiplatelet therapy and they don't actually need it? And we want it as a tool that helps us reach that decision. But I think the Ripcord 2 was a little too ambitious, and they ended up enrolling more than the trial could handle. Albeit it was a very elegant analysis that they did for cost efficacy in this trial. But again, I think perhaps the results would have been different had they been very selective in which case patients they enrolled.
Yeah, no, I agree with you. So moving on, and this is the concluding trial for the episode. And thanks again, Mirvat, for doing this for us at such a short notice. Just summarizing all the interventional trials that were presented at ESC. And, personally, a huge congratulations to you. I mean, I think as if a clinician, investigator, and a physician scientist, there isn't a better high, if you will, than to be an author on a New England Journal of Medicine paper. So this is what this trial is for you. So congratulations, and I'm very happy for you.
Thank you so much, Ankur. So this is the Master DAPT trial, and it really is my first such experience, being just a regional PI for this randomized trial. And it's very interesting because I was just telling my colleagues the other day that while we were enrolling in the Master DAPT, it was very easy because, the trial randomized patients for me and I didn't have to think. Now that the trial is over and I have these patients, it's time to stop and think of how to treat them. And I'm most grateful for the central PIs for giving me this opportunity. And it's tremendous learning to kind of be both an investigator and a clinician. The Master DAPT trial the purpose of it, or the objective, was to assess whether 1 month of dual antiplatelet therapy preserved the benefit with respect to cardiovascular events while mitigating bleeding outcomes compared with the longer regimens in patients with high bleeding risk. And the design was a non-inferiority with sequential superiority testing. Now, the importance here is that we don't have a lot of the trials that we discussed, including the trial, that we discussed earlier today, the STOPDAPT, STOPDAPT-2, and STOPDAPT ACS, the Smart Choice trial, and so on. Those were not directed to high bleeding risk patients, but the Master DAPT was. And so we enrolled patients who had either acute or chronic coronary syndromes, who had high bleeding risk, and underwent PCI in any of the coronary arteries with a biodegradable polymer sirolimus-eluting stent. And then patients were from 30 countries, over 4,500 patients, and they were randomized, 1-to-1 randomization, and the randomization with a median of 34 days after the PCI, either to an abbreviated DAPT or a standard DAPT regimen. Abbreviated, immediately discontinuing DAPT and continuing single antiplatelet therapy until the study was completed, except for those receiving clinically indicated oral anticoagulation who continued single antiplatelet for up to 6 months after the PCI. And then the standard was DAPT for at least 5 additional months, that is a total of 6 months after the PCI, and again, or for those receiving clinically indicated oral anticoagulation for at least 2 additional months, and continuing thereafter with a single antiplatelet. And what I'm most proud of in this trial is the completion of the trial, and the follow-up period happened during the COVID era. And despite that, we were able to achieve a 99.3% follow-up for these patients of at least 335 days. So the primary net adverse clinical events was a composite of all-cause death, MI, stroke, and major or clinically relevant non-major bleeding. And abbreviated DAPT was found to be non-inferior to standard DAPT, 7.5% compared with 7.7%. In terms of major adverse cardiac and cerebral events, composite of all-cause death, MI, and stroke, again, abbreviated DAPT was non-inferior to standard DAPT, 6.1% and 5.9% for the standard regimen. In terms of major or clinically relevant non-major bleeding occurring between randomization and the 335 days defined as a BARC type 2, 3, or 5 bleeding, again, abbreviated DAPT was not only non-inferior, but it was actually superior to standard DAPT at 6.5% for the abbreviated regimen and 9.4% for those at the standard regimen. And another publication just came out as well, looking at a sub-study of those who were on oral anticoagulation for whatever indication. And those also had similar results, where basically the net clinical benefit, there was no worsening of net clinical benefit in terms of ischemic risk, and there was certainly lower bleeding risk in those patients. And so I think that helps guide us that, in high bleeding risk patients, I think what this tells me is that I can safely reduce the dual antiplatelet regimen in these patients. Some of the questions that came up, is it unique to this particular type of stent, this Ultimaster stent? I think today the stent technology, perhaps, that is a theoretical question, that perhaps, yes, it is only unique to Ultimaster stents. But I think today when you look at most stent platforms, they have been so refined and so improved that I think the minor differences in stent platforms now are not the reason for any events, clinical events or subacute stent thrombosis or what have you. So I personally don't think so. But, if in doubt, you put in an Ultimaster, I guess. What are your thoughts, Ankur? What do you do in your practice?
No, so again, a great summary, and thank you for sharing this with us. And congratulations once again on being a New England author. I agree with you. I think again, this is a theoretical question. For the vast majority, a lot of the second generation drug-eluting stent technologies that we use in practice are very similar. And, I don't think I think these findings are fairly generalizable across all the stent platforms that are the second generation drug-eluting stent platforms that are, available for practicing interventionalists in clinical practice. It's an extremely important question to answer because, like we've talked about earlier in this episode, we encounter patients not infrequently which have bleeding risks which are not trivial. So, the fact that you now have a trial which supports abbreviated Dapt strategy in those patients, is both practice informing as well as practice changing. So, again, congratulations on the publication and being an investigator for this important work. Any closing remarks, Mirvat, for our listenership, for cardiologists, for early career, for women in cardiology? This is your platform and for Parallax. And again, thank you for doing this for us.
Again, thank you so much for this kind invitation. And there are just a couple of takeaway messages that I would take from the experience. One is we all need to look locally. When I look at the investigators of the STOPDAPT trial, for example, we need to know our population. We need to know it well, and we need to know what are its unique features and so on. I think looking at early career from my part of the world, what I would suggest is get involved in research early and regional research, because this is where we lack data. What we are doing is sort of adopting data that may not be applicable to our part of the world. We don't actually know if our patients have the Asian paradox, for example. It would be nice to have randomized data, or at least registry data, that helps us stratify our patients, understand our patients, and ultimately manage our patients. I think for women in cardiology, I would say seize the opportunity. And there are a lot of opportunities out there now, because I think there is a genuine interest in being diverse, in being inclusive. And I think me being here today is a prime example of that. So I'm most grateful for you to give me the platform to talk and say something today. And I think that is the only thing I would say to women. Find your passion, find your confidence. And as soon as you do that, you will find plenty of those knocking at your door, because everybody has a genuine vested interest in being inclusive and in being diverse, and in finding people with a different idea and people who think outside the box. And that's really the only thing those are the two most important messages that I have to my colleagues, both men and women. And again, thank you, Ankur, for being just very supportive to women in cardiology and to early career. And thank you for this wonderful platform. Again, I repeat what I said way at the beginning of my, when we first started this episode. It's easy to follow. It is always contemporary discussions, very easy topics, and just fantastic faculty that you bring here. So, keep it up. We enjoy it. We love what you do. And it's definitely a platform that I recommend, again, for people who are trying to tie the science to their clinical practice. You'll find a lot of practical points being raised in Parallax. So thanks again.
Oh no, that's just incredible feedback, Mirvat. And coming from you, it personally means a lot to me, because I know I put a lot of effort into recording these episodes, into getting the faculty that everyone wants to listen to, and then sort of post-processing and releasing these episodes on a bi-weekly basis. So, feedback like this from you means the world to me. So thank you for that, and thank you for listening. Thank you for being a listener. Thank you for being a supporter. Thanks again for all the work that you do, and thanks again for being such a force and such a representation for, not only women, but women of color, women of different ethnicities, varied backgrounds, women from that part of the world, and quite frankly, just a solid interventional cardiologist. So again, thanks a lot, and I'll talk to you soon.
All right, take care. Thank you very, very much for having me.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.